Oh, there we go. Now it's interesting.
Now we know.
And yeah, really anything to do with bladders, bowel, sexual health. And I'm really passionate about supporting women through menopause, because I think so many of these symptoms that we might have just had niggling in the background become very, very prominent. They can make it feel like, well, that's it. There's nothing I can do about it. I'm really passionate to be here just so we can discuss kind of practical things we can hopefully implement.
Amazing. And Pip, do you want to tell us a little bit about yourself?
Oh gosh, well, yeah, I work at Menopause Care alongside Liz, and like Claire, we've got a clinic in Richmond that I see people at, and also online, covering all of menopause and perimenopause. Obviously, today, this really, really common problem that, as Claire was saying, I think there's a kind of bit of awareness of people sort of talking about incontinence pre-menopause. I think a lot of people actually just sort of assume that it's something that, oh, well, maybe everybody has this. I'm not really sure, but perhaps it's just part of being a woman, maybe part of after having children, but anybody can get it. And like you say, menopause, unfortunately, is just a massive magnifier of so many symptoms, including incontinence. Yeah, good topic to chat about, I think.
Really good. Do you want to talk about a little bit of the reasons, perhaps, that people get incontinence and the types of incontinence? Shall we go first, and then we can work through things?
Sure. Well, I think often there's actually a mix of reasons why someone might have incontinence, and lots of people sort of think about, childbirth and stuff like that. But as I say, you don't have to have ever even been pregnant to experience incontinence. When we're speaking to a woman, we really want to know as much detail as we can about exactly what your symptoms are like, because that can help us work out what the underlying issues are. And then we can either direct you towards something like some physio, like Claire. I'm sure she'll go into all the things that we can do for like pelvic floor issues, which tends to lead more to sort of stress incontinence symptoms. So if a woman's saying predominantly what she's experiencing is that kind of leakage when she's laughing, running, that's a lot to do with pelvic floor. And then sometimes women might also experience more of those kind of urgency symptoms. So perhaps they're, feel like they might need the toilet, and then they're just about getting home and the keys in the door, and they're thinking, oh my God, it's going to happen now, and maybe even get a bit of leakage as well. And those kind of urgency symptoms might lean us a little bit more towards thinking, is there more of a bladder muscle involvement here when the bladder's getting really irritable and just squeezing before we're ready? Often it's a mix. And so we can kind of help tailor our treatment according to what we think is going on based on someone's symptoms.
And Claire, what do you see in clinic most? I know you treat all spectrum but sort of what things do you find most, or how do you base assessments when you see women?
Yeah, so we see a lot of the stress incontinence, urge incontinence, mixed incontinence, kind of a mixture of both. And I think what's really important with all these conversations is to say, like you can have one problem that leads to another problem. So you might have, that vaginal atrophy with the tissues not being quite as strong as they were. And then you've also got some urinary incontinence, which also leads to skin breakdown. And so all these things can start to connect together. And so I think with any assessment that you have with physios, doctors, it's like we will always try and take that kind of overarching care of looking at the whole vulval, vaginal, bladder, bowel perspective. Because again, if you're constipated, which also can be quite common, that can be one of the biggest drivers of urinary incontinence, and pelvic floor weakness because you're straining. And so it's really important that we never deal with any one symptom in isolation. So I guess a huge part of my initial assessment is really looking at that overall picture of your bladder, your bowel, your sexual health, your skin health, any other medical condition. And then we lead into, of course, understanding the muscles in the context of all of that's going on. I think what's also really important for women to understand is that though we hear a lot about the pelvic floor muscles, and look, I'm a physiotherapist, muscles are my bag, I love them. It's also important to understand that because of where the pelvic floor muscles sit and how they relate to the bladder and the bowel and the vagina, we are also assessing the vaginal walls. And so, the topic of prolapse is really important. And though prolapse and incontinence are different conditions, so you can have a prolapse and not be incontinent, and you can be incontinent and not have a prolapse, and you can have both together. So there are lots of ways that we are trying to establish all the time what is contributing to your symptoms, and therefore what strategies do you need? Which is why, sadly, when we just say do pelvic floor muscle exercises and
It's not.
like it didn't work for me,
Yeah.
because it's not tailored enough you and what you're experiencing. And that's why pelvic health and pelvic health physio is more than the term Kegels, which is not one I'm particularly a big fan of. It's too one-dimensional.
I mean, certainly if we're seeing a woman for the first time, obviously history is always going to be the first thing. So listening to the symptoms that they're having, but examination is also really important too. Like Claire was saying, you know, if you've got a prolapse, for example, where either you've got the uterus coming down from the top, or you've got maybe a bit of the bladder falling back into the vagina from the front, or the rectum from the back, you know, you might need some support with that, because you can train those muscles all you like, but still there's going to be a little bit of laxity, and perhaps that might mean using some additional support, like a ring pessary, for example, which kind of, imagine like a sort of silicone donut. They come in all sizes, so we might, I don't know if Claire's got any to hand. She's looking around. I can see, maybe to show us. They, you know, coming from sort of, I don't know if you can work out from the screen, but this sort of size all the way up to this, just sitting up in the vagina to help hold everything up. That's often something which women might be really nervous about having. Here we got one. But they're really easy, and women can still have sex with them in. They can take them in and out themselves if they get practice with it as well. And it can be a sort of a temporary or permanent solution to kind of help support those muscles.
Shall we just, I was thinking, I think we talk about the pelvic floor and prolapses quite a lot as doctors and physios. And I think the words sometimes get bandied around, but I'm going to assume that maybe the term pelvic floor doesn't mean very much to everybody. I knew Claire would be able to sort this question out. Shall we? What is the pelvic floor?
All the visual aids, and actually some great questions coming in, guys, about kind of like just general pelvic floor function, and it's probably some of the things that women are hearing about, like things like the term hypertonic and stuff like that. So we can dive into that. But you're right, we need to know what on earth are we talking about. So this is a female pelvis, okay, and the pelvic floor, of all the muscles in the body, they could not tell us where they are more specific. They literally make up the floor of your pelvis, okay? So these muscles here, so this is your coccyx, which is the tiny bone at the bottom of your spine. They come from there. They're sort of like a diamond. A diamond really is a girl's best friend, and they kind of literally make up the floor there around the anus and around the vaginal opening. Okay, so they're basically a group of muscles. So obviously we're quite familiar with things like bicep and tricep. The pelvic floor muscles are made up of lots of little muscles. Now within the pelvic floor complex, we also have sphincters. So we have sphincters at different places in the body. These are rings of muscles. So you have sphincters around your anus and sphincters around your urethra. And this is where continence of bladder, bowel is also more than just the pelvic floor muscles. The names is actually your sphincters as well. And so that's all part of the picture as to how we activate the pelvic floor. We also want to think about how we activate the sphincters as part of them. So that's the base of where the pelvic floor are. And obviously, anytime you exercise a muscle, they can get stronger. But the problem, as I find with pelvic floor muscle exercises, is we don't really think about them like other skeletal muscles. So I think we're all quite familiar with the concept of strength and conditioning when it comes to other muscles. Like you go to your Pilates class, you make them exercise more challenging. You maybe lift weights and you incrementally make that weight heavier. It is these challenging processes that make muscles basically adapt to demand. When it comes to pelvic floor, we're there like, we did a few squeezes here and there, and we wonder why the symptoms don't improve. Okay. Now, no one's wrong to do that, because that's how we're guided as women. Like, it's sort of very wishy-washy and a bit of this and a bit of that. It is like any other skeletal muscle. And if we do not challenge it enough, and we don't actually get the muscles working better in different positions and for the task that we want. So in the same way, if you had a hamstring injury and you wanted to run 10K again, if I only told you to bend your leg forwards and backwards 10 times, a few times a week, that's not going to rehab your hamstring to run 10K. Okay. So me telling you to squeeze your pelvic floor a few times to help incontinence is probably not going to get you running 10K dry. Okay. So this is the gap that physios sort of feel between maybe some online advice and getting you dry. And it's that incremental plan related to you that makes the difference. And that's something that isn't communicated, I think, within the pelvic health conversations.
Yeah. One of the questions is great, actually. Well, there's loads of great questions, but somebody has written, and I've had patients ask me this. what happens when you go to an appointment with a women's health physio? What does the examination involve?
Yeah, absolutely great question. And I think a lot of the fear can stop women coming. So we're going to chat like we're chatting now. You know, I'm very much like, this is how I chat in clinic. We ask you, and I think it can be scary to go and talk to someone about your bladders and bowels. And I'm sure Liz and Pip Foyley, you know that feeling from patients. But we talk about this stuff like the weather. So this is very comfortable for us to talk about. We'll guide you through the assessment, but essentially what we're going to do as physios is we are going to do a vaginal examination, which I think is completely a head shift from what you think a physio is ever going to do. But the only way we can examine the pelvic floor truly and honestly is to put our finger inside the vagina and feel round onto the muscles. We'll also check the vaginal walls. Now, generally speaking, we wouldn't use speculums unless we are doing pessary fittings. And some of us physios have done additional training to also fit pessaries to supplement and support the care that we give you. But generally speaking, that's not used. So it's not a painful examination unless you're also someone who's got some vulval pain or maybe some other conditions. And we obviously only tailor this to what you're happy with. But then we also, the majority of us now will also assess you in standing in that kind of mindset of we need to get your pelvic floor working in a functional position because most of us don't leak when we're lying down. So that is it really. We teach you, we're looking at what you can do, we're trying to help you do it better, we're trying to make it work for you, and then bring it all together at the end of the assessment to explain a plan, find out what we found. And obviously you may have already seen a consultant or you might have seen a GP, and so we're just building on that picture to implement a plan as part of that. And sometimes people come to me and then I refer them to doctors to also bring the medical part, and sometimes it's the other way around. But the idea is that we're trying to be a team to bring in maybe a hormone part of it, a structural part of it with a pessary, your pelvic floor part of it, and all together, and maybe a bit of constipation management as part of it to make your symptoms better.
Yeah, it's definitely working sort of exactly like you say, as in conjunction with each other. I don't think you're not going to get the benefit from just seeing the doctor or just seeing the physio, I think. And so if I'm examining a woman, for example, whilst I'm looking at the pelvic floor too, you know, someone like Claire's got much better expertise probably assessing and managing that side of it. I'm also looking at things like, as I mentioned earlier, like the prolapse. Is there something I can offer, like we both do pessaries to help with that? Or, you know, would the woman even want to consider surgery? And whilst often that might be kind of a second line thing, some women would prefer to consider that than the idea of having a pessary all the time. But I'd just put one caveat to that, and perhaps a gynecologist might argue differently, but there is a level of impermanence with surgery. Whilst you might think it's just a fix all and then the problem's sorted, sometimes we do find that the surgery is done and then everything becomes a bit more lax again, and partly that's to do with estrogen. So again, that's perhaps
should we talk a bit about the hormone changes moving
I mean, hopefully ladies or maybe men as well who are watching this may be a bit sort of aware of from discussions before about obviously the importance of estrogen and the changes that women will experience in menopause. But when we talk about the effects being absolutely magnified in this area about it during menopause, is because we've got estrogen receptors all over the whole body. So that's why we see symptoms that are so vastly ranging in women who are perimenopausal and menopausal. But the bladder, the vulva, the vagina has got a massive, massive concentration of estrogen receptors. So that's why you're going to see such an enormous change in this area. So the role of the estrogen in here is in providing a large amount of elasticity. So, you know, women often see changes in the skin on their face, and that's visible to you in the mirror. Yeah. Imagine that times 100 down below as well. And, you know, Claire talked earlier a little bit about sort of just looking after that part of our body. I always sort of speak to people about the pandemic, when we were all wearing masks on our faces. And, you know, a lot of people saying, God, my skin is awful. You know, the humidity from the mask behind it, the rubbing of the mask is horrible. If you're wearing underwear in a moist environment, which it is down there, then you're going to have the same effect. And we perhaps just don't take as good care of our vulva and vagina as we might think of, like what we sort of spend and take time on with our faces. So we need to be kind to it. So I'll come back to sort of what we can do about that part of it. But coming back to the estrogen effects, we're losing that elasticity. we're becoming a bit drier. Claire mentioned, we're looking also for things like vaginal atrophy. What we mean by that is when you look at the sort of the skin on the inside of the vagina in a woman who's got vaginal atrophy, it looks a bit drier. It's definitely less elastic. There's an appearance to it which you can definitely see in pretty much any woman who's going through menopause. And putting estrogen back into those tissues, it can be a really core part of managing incontinence, actually. So, women, if they are on HRT, or even if they're not on normal systemic HRT, can use vaginal estrogens. And I recommend it really to nearly all of my patients.
Incredibly safe, aren't they? Incredibly safe, incredibly important.
Exactly. Even women who've gone through breast cancer. And I think this is an important one to say, because obviously, if you've been unfortunate enough to go through something as dreadful as breast cancer, even talking about hormones opens a whole other sort of can of worms, and people can be very fearful about using estrogens. But the vaginal estrogens that we use are working so locally on the vulva, the vagina and the bladder, that they really don't pose a risk to women who've had breast cancer. So anyone can use them, and as long as you physically can put these things in, you can carry on using them forever, whether you stop your other HRT or whether you don't choose to go down that other HRT road. And as I say, it's affecting the vagina and the vulva, so how comfortable you are down there and how elastic those things are pinging back and holding up your pelvic floor, but the bladder as well. So even the muscle of the bladder, separate to the pelvic floor, has got loads of these estrogen receptors on it too. And what can happen is that muscle can become quite irritable when it's estrogen deprived. And so that's when that kind of urge incontinence picture comes in, and the people are sort of finding that their bladder's just squeezing completely out of their control, making them have to run really urgently to the loo. So just using vaginal estrogen can have an impact on that, even aside from doing all pelvic floor exercises as well.
Yeah, I agree. I think for me, it's two separate things. I think there's a lot of narrative of like, oh, well, menopause just, the estrogen decline makes your muscles weak. It's actually an incorrect assumption that I think is often made. You age and your muscles weaken, process of sarcopenia, and because your pelvic floor is a skeletal muscle, it will also weaken. So that's going on. In parallel with that is the estrogen element, which is why we need both, and we know that pelvic floor muscle exercise, they've looked at research, improves elasticity and improves blood flow. Also great for the mucosal tissue. So it's one of those things that they kind of like love and support each other. And
as well as vibration as well, I was going to say.
Yes,
too. I don't, again, like some people find it a bit of a taboo subject, but using vibration in that area on your own or with somebody else also increases that blood flow. So I say to women, please do go ahead. Use this.
Orgasm is good in many ways, physically and emotionally and every other way. There's a question here about can physios assess vaginal atrophy and GSM, genitourinary syndrome of the menopause? I think my short answer would be we can definitely say the signs that we have seen. So it depends how skilled and trained the pelvic health physio are. I've done this for over a decade. Other people won't have done. So yes, I pick it up and I would refer on. So this is the thing. I'm not treating it. I'm saying I see these signs and I'd say to the doctors, please, could you support this lady? I'd probably suggest to the lady, I reckon they might put you on some vaginal estrogen. Would either recommend with the GP. So yes, we can, but we're not going to directly treat it, if that makes sense.
Just
talk about treat. Should we quick? We will do it really quickly because otherwise we'll run out of time.
Yeah, I was just going to say, would it be helpful maybe just to chat about it? Because there's quite a few different vaginal estrogens that are used. And again, it's very individual and often are just about explaining about how each of them work and what practically you feel would be most useful. So a very common one that women start off with is a product like Vagirux, which is a little sort of like a little waxy tablet. It sits on top of an applicator, quite similar to a tampon applicator. Thank you, Liz.
Tablet in there.
It just goes in the top. So if there are ladies who do struggle with their dexterity, it can be a bit of a fiddle using those applicators. That's a bit of feedback we get. It's fine to use a bit of lubricant on the end of it as well, just to help it go in, or you can just use a finger. That's the simple way of doing it too. So when I say put it in, this is going into the vagina, just to be clear. And we normally say to him, put it in at night. Gravity is not always our friend. And if it's going to come out in the daytime because you're upright, that's, less comfortable. But then some people just don't get on with the idea of sort of putting a tablet inside like that. They might prefer to squirt something up inside. So we've got these creams that work very similarly, come in a syringe that you can put inside. Actually, I often prescribe that together with the pessary because you can use these creams externally. So we didn't talk much about the vulva today, but sadly, some women get really uncomfortable, dry, even cracked skin on the vulvas, which is incredibly painful. So again, really want to be kind to our vulvas, not using soaps and things on there, using things like moisturizers to wash and even applying it afterwards, just as a barrier and to moisturize the skin too. But using these cream estrogens can be quite good. There's even a gel version, which again, if you are very cracked, some ladies sadly do find it's quite, the creams can be a bit stingy, and sometimes the gel is a little bit more comfortable for them to use. But again, lots of different options. So worth talking to your doctor about those.
Can I ask, there's quite a few questions about pelvic floor in the chat here.
Yeah, I noticed there's loads of questions about pelvic floor. You answer some of them, Claire. Pick which.
There's a few that have come through about this term hypertonic.
Hypertonic, yes. Yeah.
Right. So language is really important, and actually hypertonic is not really the term that and I'll explain why. So really hypertonicity is what occurs in a muscle when there is a neurological, more kind of higher up, something in the brain. So we've had a stroke, there's maybe another neurological condition which truly drives a hypertonic. So this is where there's kind of like spasticity within a muscle that we cannot change. Okay. That's different to what's happening within the pelvic floor. Now, if you have a neurological condition, that's a different conversation. But for the majority of the population, that's not, when we say this word, is what people mean. What we're really talking about is actually just the term tone. And the reason that's important is because we can actually change that. We can't really change hypertonicity. We can change tone. So tone is in all of our muscles. It's why I'm not jelly on the floor and I can sit up here and I can talk to you. It's partly because of my muscle tone, okay, working with my skeleton. And your pelvic floor is the same. So we all have a resting tone. That tone can increase. That concept of everything being more switched on, a bit like the stress shoulders, okay? That's an increased tone in our trap muscles. Relax those down, okay? The pelvic floor can do the same thing to stress, to pain, pain with intercourse, childbirth trauma, being worried you're going to leak, feeling the sensation of prolapse. So a lot of these things are subconscious. It's not like you're sat there being like, I now want to increase my pelvic floor tone. It just happens over time. And then through other processes like vaginal births and stuff, there can be a decrease in tone as well. So really what we want to do as physios is partly looking at your muscle tone to understand where do you sit naturally. Because for some women, and this is why pelvic floor, the Kegel concept doesn't work for many women, because you're for already increased tone, think about an arm, you're already, this is your rest position. All the ability you have is this to squeeze, okay? Now, of course, if you're then trying to jump, your pelvic floor can't really respond because it's not actually fully relaxed, okay? So it needs to be able to work through movement. When we move a muscle through movement, it can get stronger. It also has better function, okay? So that's a really important thing, and that's where physios can assess tone, muscle function, and make a plan for you. There's some questions here about like pelvic pain and adenomyosis and the relationship of these to the pelvic floor. So adenomyosis being a condition of the womb, and I don't think we've got time to go into the actual process of that, but essentially women will live with high levels of pain for a long period of time, many, many, many years, generally cyclically, but it cannot be as well. Anytime we live with pain in the body, muscles will respond and change, and neurologically we change as well. So yes, we see with a lot of people, and I treat a lot of people with endometriosis and adenomyosis, their pelvic floor tone will naturally just be very increased. Their body's almost in high alert. It's fight or flight. When's the next pain coming? And if you imagine someone punching you in the belly, what do? You recoil and you tighten. So it's like your body's in that sort of response all the time. So yes, it can impact your pelvic floor muscles indirectly. Doesn't mean that that won't, or then maybe lead to pain with intercourse and other things like that, because your pelvic floor muscles need to be relaxed to allow penetration, smear tests, tampons, stuff like that. So really great questions, but yes, all part of what we are establishing and helping you hopefully through your assessment. There's another one about chairs. Can I quickly talk about those?
Oh yeah, go for it, Claire. Yeah.
So look, I'm a real believer there is a place for everything. Okay, so essentially what these chairs are is they are stimulatory devices. So we have used muscle stimulation in physiotherapy, full stop, across decades. Okay, so it's not a new concept. but basically what's happened is there's new high fem technology, it's called, which now sits in a chair and you can stimulate the pelvic floor muscles just as we're sat here chatting. No one else can see it, you are going to feel it. Now, these chairs can be very, very effective for the right person with the right symptoms. However, it is a muscle stimulation device, so we should be establishing through assessment if that is indicated for you. Unfortunately, what's happened is obviously, like most things in women's health, we've seen, oh, businesses are like, brilliant, we can make tons of money out of this. And it's become a little bit too, this is the solution to everything. But as you've probably established through this chat, tons of things can be influenced.
One size fits all. Yeah.
So you could go sit on a chair and it might help your pelvic floor muscles get a bit stronger for a couple, for a bit. But again, even if you put one of those old ab trainers on and you did that for a few weeks, yeah, your muscles might look a bit toned. If you no longer use that muscle, they will no longer stay toned. Okay, muscles need constant use to keep that process of strength and what we call hypertrophy. So yes, part of the picture might be really helpful. How they're marketed, absolutely not. So that's where I think, again, it's just making sure that you're using it in the right way for you. And I'm not against them. I actually have used them for some women. I think they've been incredibly effective, but it's how it's used rather than what it is.
I'd be interested to know, Claire, how much you talk about in your clinics as well about not just the importance of obviously continuing to train those muscles and continue to do pelvic floor exercises, but also sometimes how we can negatively change our bladder training. So again, with the bladder being a muscle around the sac that is containing urine, what I often see is women who have kind of self-trained their bladders into responding a certain way, which isn't always helpful. And completely understandably,
by doing a just in case wee.
Yeah, absolutely. We're all, you're thinking, oh gosh, well, I'm about to go on a long train journey or something. I'll do a just in case wee. And just like potty training a child, where you're trying to get them to go a longer time and wee in an appropriate place and not through the night, for example. Obviously, different hormones as well involved in that, but we can train our bladders to need to go for a wee too frequently. And so sometimes if I think that's what's happening with a woman, I actually will say, look, here's a diary. I want you to write down exactly when you're going for a wee. Sometimes ladies come and say to me, I'm going for a wee every 20 minutes. Now, it might be that they've got some detrusor muscle instability, which we talked a little bit about before, and there are different medications that they might need for that to help them relax the muscle. But it might also just be that they need to train themselves out of it, which takes some time and some patience. And what we might say is, right, okay, now you're going for a wee every 20 minutes. What I'd like you to try and do for the first week is every half an hour, and just incrementally extend that to train yourself into sort of a better pattern. I don't know if that comes up a lot with you, Claire.
Yeah, tons. And I do a lot of bladder diaries as well. So very probably similar approach. I guess the things that we then would try and bring in as well is understanding the relationship between the bladder muscle being that smooth muscle, not in our conscious control, in the sense that you can't tell your bladder to contract like I can do with my arm, and then the pelvic floor relationship, because there's an inhibitory reflex that goes when we squeeze our pelvic floor and you can hold it for 10 seconds. It actually helps to calm down that detrusor muscle that you're talking about. So we can bring in other strategies to help the woman feel more confident, and also look again, like you would do, like what they're drinking, how they're drinking. And there's so much, again, negativity, I think, about, give up all of these fun things, like all the booze and all the caffeine. And I'm like, don't worry, I'm not the fun police. But and to be honest,
it does make a difference a little bit, though. The caffeine, unfortunately, does.
But for some people it doesn't, and that's what I find really that's why the bladder diary is so important, because you can then really see, is it relevant for them or not. I agree, if we're necking 10 cups of teas a day, we've got to understand it's going to have a change. However, I think sometimes it's just thinking how they're drinking it, because the other thing we often do is we're like, oh, I really love this cup of tea, and we neck it really quickly because we're like, it's so good. That quick filtration also can increase urgency in the bladder through what it does to the lining as well. So it's just one of those things that, like, it's just being so dynamic in how we look. And as you've mentioned, the estrogen that might also help as well. So yeah, absolutely similar approach. And we would just try and give as many strategies as possible to make those changes. But as you say, it doesn't happen overnight. It's about chipping away at it over time.
Someone's asked, actually, can you buy vaginal estrogen? I think there were a couple of questions about vaginal estrogen.
You can actually.
And so Gina or Gina
I'm never quite sure how that was pronounced.
License to be
Yeah.
sold over the counter, which is this. So it's the one with the applicator,
Yeah.
and that's great. It's only can be sold to postmenopausal women. That's the license for over the counter purchasing. The only thing I would say is that vaginal estrogen, if you're going to use it, generally is a long-term thing. So you don't, what they sell you is a relatively small pack that will get you through a couple of weeks, but really,
It's going to add up, isn't it?
it's going to add up. I don't know whether they're able to just keep giving it to you if you keep going back. Actually, I'm not sure about that. So it's great that it's been made available in that way, but it is a very reasonable thing to get on prescription in slightly bigger quantities. With most of it, you would use it regularly for a couple of weeks and then drop down to a couple of times a week. But yes, it is available.
Questions about NHS resources here with the physio, and there are pelvic health physios like me on the NHS. I used to run a team in London, so we are there. We appreciate the waiting list is often a lot longer, but it is accessible. Someone's asking about the Squeezy app. Yes, I think it can be a helpful reminder. Again, it's not tailored to specifically to you, and you need to, it's very, you're not going to know exactly what's right for you, but I think it's a really helpful
Good
start.
reminder.
And
I often tell people about, even if you've not got the app or you're just not an app person, just sometimes it's associating doing your pelvic floor exercises with something else that you do as a trigger. So if you're going to brush your teeth twice a day for 2 minutes, do your pelvic floor exercises while you're there.
yeah,
At least it's something. So
habit stacking and stuff like that.
That's it, yeah.
There's also the POGP, which is like our governing body of pelvic health physios, and they have tons of free resources on the website. You can also access it in any language. If you obviously you're visually impaired, there's audio. So that's a really lovely place to start if that's helpful for anyone as well.
I think that's a really good place to start. There is, and like you said, there is availability on, as in you can, I believe, in most areas self-refer to women's health physio.
I think it's a bit of a slight postcode. And huge waits. I mean, I'm an NHS GP as well, and in our area, it's sort of 9-12 months wait.
Yeah, I think that's the tricky part, the length of waits. When you know that you really could do with some help, you would quite like help soon, wouldn't you? That's the
I think what I sometimes say to women as well is it can then feel like if you're having to go privately, that you're then committing to this entire private pathway. And I mean, I can't comment for all physios, but I really believe in accessibility. So sometimes women will literally just say to me, I can only afford one appointment, but I do want to come so I can make a plan for myself. I am more than happy with that. I'm not here to sell you 10 sessions of physiotherapy. I'm here to help you get better. So sometimes women, or they'll do a little bit of cross cover. So they might see a women's health physio in the NHS, but then it's like 7-8 weeks before they see someone again. So I think I'm a real believer there are so many models of care. There's virtual aspects, there's other things that we can make good differences. But there's anything from free information all the way obviously up to regular private physio, but there's a lot in the middle. And if anyone wants signposting, I try and do a lot of that. So I always try my best to signpost alongside obviously any other care that you're receiving.
Somebody's asked an interesting question here about they're on systemic HRT and asking, can you use vaginal estrogen at the same time? And do you need more progesterone?
100%, definitely. Please use it at the same time. I rarely don't encourage women to have some vaginal estrogen, with alongside their normal HRT as well. So you don't need to worry about it being a sort of an additive and feeling like you're going to be overdosed on estrogen. Think of it as a standalone. As I was saying before, even women who have had breast cancer, for example, and maybe are suggested not to use normal HRT, can use this alongside. So definitely. And to answer the bit about the progesterone, because it is just working locally, no, you do need to obviously use the right amount of progesterone with your whole body, systemic HRT, but you could use the vaginal estrogens just entirely by themselves. You don't need progesterone to counteract the estrogen on that part.
And someone's also said, can you get vaginal estrogen as part of the prepayment certificate yes, that's one of the things that is, I believe, included in the the packets to do with that.
I think so, yeah. I think the only thing that isn't would be testosterone, but that's a bit of a lottery again as to whether the NHS, you can get testosterone depending on your local area.
This is a good question, Claire. I don't know if you know I imagine you do know the answer. What qualifications should women be looking for if they're trying to work out, like, what is a pelvic physio or a women's health physio?
Yeah, so yes, the title should be Specialist Pelvic Health or Women's Health Physiotherapist. What I actually really recommend that you do is try and go on to the POGP website. I've actually just answered someone's question. It's and I've just asked Simon, who's with us, to just add it into the general chat, the website. You can
Brilliant.
go on there and search in your local area for those that are members of the POGP. And so these are pelvic health physios that are really dedicated to kind of expanding their career and doing ongoing learning. That's someone I would really recommend you look for, or someone that has significant levels of experience. There are different levels in the same way there are in every area of medical professionalism, in the sense of you could have done a weekend course and then do it, or you can have done multiple advanced courses. So yeah, that would be my kind of general starting point, is look via that website for your local area. If you're London based, I'm always happy to try and signpost people if that's helpful, because that's where I'm based, and so I know a lot of the network here, and we're always looking to get you in with the right person.
There's a couple of questions, well, there's quite a few questions that came through in the sign-ups, and then another one here a little bit about time scales for how long do things, and I mean, I always practically have the same answer for everything with this, but so it's sort of talking about vaginal estrogen, still getting discomfort, or if you do like non-invasive techniques like exercises, what sort of answers do we generally give to do with time scales? Like,
I would say from the estrogen side and sort of from your medications to work, kind of probably the same, Liz, as you were saying with so many hormonal things, is 2 to 3 months, I would say. I mean, anything that you're putting on topically, so direct onto the skin, there will be an element of lubrication and moisturization as well. And I'm always banging on about lubrication to both oil-based and water-based to work together to like sort of glide over one another. But from the hormonal point of view, that's probably the amount of time to give the full to see the full benefit of it. But I would say to any woman who's using these products, if you're using them and quite quickly feel like this is uncomfortable for me, tell us, because we can then change to a different preparation that might be a bit better.
I think also with vaginal estrogen, though, it does depend a little bit of your starting point. So
true, yeah,
things are quite mild, the tissue isn't too irritated, it hasn't been like that for a very long time, and no, you've not felt confident to ask anyone or not known you could ask anybody. Sometimes in the same way that if you get some sunburn and the cream that's going to soothe it will feel like you're putting like fuel on a fire to begin with, I do think, unfortunately, these products can be initially quite irritating, and there is some settling down period and a little bit of trying to assist, sort of persist. And I think for women who perhaps then using it in conjunction with supportive exercises and time, I think they can possibly even take up to 6 months to start getting the really full effect of recovery of tissues.
I think it's getting that reassurance to carry on often.
And then the keeping going with it. And I think most of us do sometimes adjust the amount, so a little bit sometimes beyond the license, because we know so much about the safety, or add products together, or like you mentioned, Pip, discuss even sometimes changing products if it's not suiting you or it's inconvenient for the use.
Not and sure. Remembering the non-hormonal products as well. So like I said about lubrication, but also using something on there as just a barrier, particularly if the skin's cracked and sore. But coconut oil, just an unscented moisturizer, can go a long way. But just to throw a little caveat in here as well, I think if it's not working and you're particularly sore or itchy, it is really important to be examined, because there are other conditions that we often see around the same time as menopause, like lichen sclerosis, for example, or even vulval cancers, that can give exactly the same symptoms. So especially given that some of these products are available over the counter, and by all means, like we say, try them. I think if something isn't working, it's always really important to be seen, be examined, and just to make sure that you don't need to be dealing with something else. You might be given some steroid cream, for example, for lichen sclerosis, to stop the itching, to stop the thickened skin. So a different condition, but just to be important not to forget about those as well.
I'm really aware of time, and we've got such a good conversation going on, but we'll need to wrap things up soon. But one thing I just wonder if we should quickly touch on, I noticed something that reminded me in the chat, is to do with how many women either believe that they're getting more recurrent thrush, or actually are getting it, or feel like they have it. I know that's not related particularly to do with urinary incontinence, but it's the same area. And
the UTIs as well, I think.
UTIs, like, is it a UTI? Have I got a urine infection?
Yeah.
Is this thrush? What's going on? Very similar, mimicking symptoms.
Or even sexually transmitted infections, because I think whilst it's sort of, a lot of people think, oh, that's young people being promiscuous or something. Anybody can get a sexually transmitted infection. So again, always make sure that if you are a sexually active person, that you get checked. Thrush, though, yes, you can get thrush, but I would say, whilst I see a lot of women who come along and say, I've been so itchy and I've treated myself 8 times with Caniston and I've tried the pessaries as well. Actually, thrush often lives in an environment where there's high estrogen. That's why lots of women get it in pregnancy, particularly because they are in such a high estrogen state. So I tend to see less thrush symptoms, but not actually thrush. And so particularly, again, if you're having recurrent symptoms that you think's thrush, we should be doing a swab and to see whether, yes, it might be thrush, but actually, is it just that there's something else going on, like vaginal atrophy and vulval atrophy, or lichen sclerosis, or something like that needs treating. And similarly, the cystitis symptoms as well. It's that irritable bladder that we talked about earlier, the dryness, the propensity to UTIs, unfortunately, because of those circumstances as well. It's sadly very common. But the incidence of UTIs is massively reduced with the use of vaginal estrogens. So that's always worth thinking about before sort of assuming that you need to take maybe prophylactic antibiotics or something like that.
And I think also the change in hormones through this phase will impact our vaginal microbiome. So there's bacteria in our mouth, in our guts, in our vaginas, and that change in hormones and slight shift in it can sometimes make us more predisposed, not later in menopause, but during this transitional phase, to perhaps episode of thrush. And that is sometimes where giving back some estrogen and smoothing the waters a little bit again can be.
Or even, again, when women have understandably sort of tried to sort out their symptoms, maybe use some of the vaginal washes and things like that, thinking, oh, I've got infection, I need to sort of clean to get this away, this discharge I've noticed. And actually what you're doing there is removing the normal, good, healthy bacteria that we're meant to have there, and just leaving a gap for perhaps the more unhelpful stuff to get in. So yeah, I can't stress enough. I'm sure if our colleague Charlotte was here, she's our vulva expert, would be all over the please be kind to your vulva conversation.
It's been brilliant talking to you both today, Pip and Claire. Do you want to, if you got one last thing that you want to say, or anything that you think would be important to sort of a final thought? Claire, anything?
I mean, my side, again, muscles take time to change, and actually if you're starting from a really weak point, you need to, you're not going to have a body transformation by going to the gym for 2 weeks. Those take about a year. So the muscle tissue can change over time with the right input. But what I would say, if Kegels have not worked for you, That does not mean that pelvic floor rehabilitation will not. It's just that it's been too one-dimensional and we haven't done the full picture. I appreciate getting support is hard, but I do believe the right information is out there, and it's just trying to get through the noise of that. And maybe we can support trying to get a bit more information out there on that. But I think it's just, yeah, don't feel like it hasn't worked just because it's been Kegels. There's way more to it than that.
Yeah, absolutely agree. Absolutely. I think Pilates is absolutely brilliant for doing the pelvic floor, as in not having to think about the actual exercises, but you're going to do something you enjoy, it engages it, but you're also doing a mindful activity. You're seeing people, well, if you don't do it online. Yeah, for me, that's been incredibly helpful.
Yeah. We know that being active is good for all muscles.
Being active, exactly.
Yeah. The only problem I sometimes see with Pilates is because there is so much queuing to the squeeze. All these women come in and they don't know how to let go. They're just like on. And I'm like,
yeah, that's true. And the same with shoulders, squeeze.
Yeah.
It's like
dynamic.
yeah, flow.
Yeah.
Oh, it's been great to talk to you both. Thank you so much. Thank you everyone who's been watching, questions as well.
Claire.
And yeah, I'll say bye and have a wonderful Friday.
Thanks, guys.
Bye.
Bye.
Bye. Bye.